the MSE was famously placed more posteriorly, but there were lots of failures because the MSE TADs would drag through the thin bone. But the ease expander, and along with Kasey Lee's sort of mysterious surgical assist, this expander is able to purportedly achieve posterior expansion, a parallel front to back, as compared to the custom MARPE or MARPEs in general, which achieve this sort of more conical expansion.
I personally waited 10 years to be able to expand myself without surgery. So I'm a very strong advocate of a minimal invasive approach. So if you can avoid surgery, you have to avoid surgery, because I think the outcomes could be more superior and less invasive and more gentle to the patient, to the bite, to the teeth, to the airway if you do it without surgery. I definitely agree that there is a strong argument about what type of expansion we are getting with EAS, MARPE, non-surgical protocol, surgical protocol, and MSE. Argument is very valid. The theory is that for the purpose of improving the breathing, we want to achieve more posterior expansion. Although this is a great concept and a great idea, we have zero studies today that suggest that opening the posterior portion of maxilla will improve breathing. But I also want to say that the claim that you can only achieve anterior posterior parallel expansion with ease is untrue, because you can achieve parallel expansion from the front to the back with other non-surgical type of expansion protocols.
Okay, and I want to dive into that. So, doctor, my purpose today is going to be to try to steelman the argument that people are making that um, the custom MARPEs and MSE, as it's being currently done now with interior placement, they're arguing that this creates a conical expansion that's mostly anterior, and that there's not sufficient expansion posteriorly, especially inside the nose and at the back of the maxilla and at the approaching the pharyngeal airway where sleep apnea patients need it most, and that therefore custom MARPE and skeletal expansion, as it's done in 95% of cases, except in the case of ease, which they like to point to as a good way to do posterior expansion. There, a lot of people are saying that the MARPEs are not worth doing at this point because the expansion is too anterior, not posterior, not enough airway benefit. So I want to defend that case and then maybe have you try to push back against me and make a case on behalf of the MARPE as you do it, which is the custom MARPE from the partner studio. Dr. Lipkin also does that style. I think you and Dr. Lipkin are very similar in terms of your appliance design and placement. So that's what we're going to do today, okay?
Sure. So, all right.
Do
Let
you want to come right out and comment on anything I've said so far, or do you want me to jump right into making the Steelman case
Mhm.
in defense of the opponents of the MARPE?
Sure. So I definitely agree that there is a strong argument about what type of expansion we are getting with non-surgical protocol versus with surgical protocol, with EAS, MARPE, and MSE. The argument is very valid, and the theory is that for the purpose of improving the breathing, we want to achieve um, more posterior expansion. Although this is a great concept and a great idea, we have zero studies today that suggest that opening the posterior portion of maxilla will improve breathing. When I look at my patients with maxillary deficiency that would benefit from expansion, there is a very large range of deficiency in the maxilla. Some patients could be very deficient in the more anteriorly deficient. Some patients are very narrow from the front to the back. Some patients present with severe septal deviation at the level of the bone, and some patients present with significant uh, internal nasal valve collapse. Those are different, or both. Those are different types of phenotypes that patients have. And with today's technology, we can customize appliance for the patient. We can, there is no question, if you place the device and if you place the implants more anteriorly, you are going to achieve more anterior expansion. If you distribute forces more posteriorly or evenly between the front and the back, you are more likely to achieve more parallel opening of the midpalatal suture. So today, we are practicing with the technology where we are basically limited by our imaginations when it comes to appliance design, based on patient's needs. If the patient needs more anterior expansion to address severe anterior crowding, to address some type of anterior crossbite, to address internal nasal valve collapse, then we probably want more anterior expansion. But if the patient needs more posterior expansion, we can design the appliance so the implants are more posterior or evenly positioned between the front and the back of the maxilla, customize the appliance and try to achieve more posterior expansion. So it all depends on the patient's needs. Every patient that we treat has a CBCT prior to treatment, and I customize the placement of the implants, customize the position of the screw, customize the anchorage on the teeth when it's necessary, and design the appliance based on the patient's needs.
So,
Mhm.
so you question the very premise that you can universally declare that posterior expansion is generally better. You think that it needs to be taken patient by patient because a significant number of patients you're suggesting actually need a conical or more anterior type of expansion.
Yes, there are a lot of patients that would benefit from more anterior expansion. Um, but there are a lot of patients that would benefit from more like parallel type of expansion. And I
Mhm.
think we have the knowledge in terms of anatomy when we study patients' anatomy from the CBCT images to design the appliance which would be best for them. When it comes to improving sleep apnea or to improving breathing through the nose, we don't have a study that suggests that the posterior expansion is the must, because nobody looked at those different phenotypes, anatomic phenotypes between the nasomaxillary different types of anatomy to really say that posterior expansion is a must. I had patients that had significant improvement in the nose score and the sleep apnea parameters, and they had more anterior expansion. And then I had patients that had beautiful parallel expansion from the front to the back, and they still needed an MMA surgery. So I think this is all a great discussion, but until we have a good study, I think this is just a speculation and our logical argument, but it's not scientifically proven.
Let me ask you your opinion on this diagram here. Have
Mhm.
you seen this image before?
Yes.
Okay. Do you think that this is scientific, or do you think this is pure armchair science theory?
I think this is theory.
So what this is suggesting is that with, for example, the ease.
Hmm.
So this seems to be a pro ease sort of publication. It's saying that uh, ease is getting it's almost triple the amount of increase in, I believe this is nasal volume. I'm not. Could you explain this? Do you understand what is being shown in this graph?
Hmm. So this is basically depending on the type of expansion from the front to the back. This is just a diagram. This has not been done on real patients uh,
Hmm.
to um, to really confirm this diagram. Based on it's not clinically based. It's a great diagram. It basically shows the change in the volume of the inside the nose with different type of expansion.
Hmm. And
I think
so,
geometrically, I think it's beautiful. It makes sense, but we are talking about clinical parameters of sleep and breathing, and we cannot really apply this diagram directly to the patients. I get patients that had ease, and I don't see much expansion in the nasal cavity after the ease. And I had patients that had non-surgical expansion, that had a beautiful parallel opening all the way from the front to the back. I had a lot of surgical assisted cases, where they had traditional surgically assisted expansion where they didn't even open in the back. And I
mhm,
had patients that had the piezo done from the front to the back. There is a cut in the back of the maxilla at the level of the PNS, posterior portion of the palatal processes, and there is no expansion. Sometimes when you make a cut, you see that you think that, oh, that's widening of the suture, but it's just a surgical cut in the bone, and there is no widening at the level of the concha, posterior nasal concha, at the level of the uh, um, retronasal pharyngeal space. So I think this diagram is great. Geometrically, it totally makes sense, but there is no evidence to suggest that ease is the only procedure that offers the parallel expansion from the front to the back. And I had patients.
okay, so
Yes.
you're saying a few different things. You're
Hmm.
saying that uh, this triple increase in volume that this diagram is trying to suggest that ease gives as compared to a MARPE, you're
Hmm.
saying this does not pan out in terms of patient experience of airway improvement. That's one thing you're saying.
Yes.
You're not getting uh, patients reporting triple the improvement with an ease as compared to with a custom MARPE.
That's correct. But I also want to say that the claim that you can only achieve anterior posterior parallel expansion with ease is untrue, because you can achieve parallel expansion from the front to the back with other non-surgical type of expansion protocols.
Okay, and I want to dive into that. Let's lead into that discussion with some more images. So, um, the ease. Okay, this is what the ease expander looks like. This is the KLS Martin expander.
Mhm.
My understanding is that it requires cutting into the gums in order to install it, but critically, the way this expander works is that it's placed posteriorly, which is to say further back than um, a custom MARPE, which would be represented here on the right, which is more anteriorly placed in the denser part of the maxillary bone, which is toward the front. Because as we get to the back toward the PNS, the posterior nasal spine, the bone gets thinner. Um, and that is borne out in this image, which is a graph that represents bone density in the maxilla based on location. In the front, well, on the midline, we have dense bone from the front to the back. But as we deviate off of the midline, the bone density is more in the front. This yellow represents 4 to 6 millimeter bone density. And as we go farther back, it gets 2 to 4 in these sort of salmon colored blocks. And then the red blocks are very thin bone, which would be, posterior placement. Here we have the molars, and the bone is very thin as we flank to the side of the mid palatal suture line. And so, the MSE was famously placed more posteriorly, but there were lots of failures because the MSE TADs would drag through the thin bone, and perhaps for other reasons. But the ease expander is posteriorly placed into the alveolar bone, which is to say the force vector of the TADs or the placement of the TADs is parallel to the direction of the expansion, as opposed to perpendicular to it with typical MSE TADs. And so it's pushing into the alveolar bone posteriorly, and along with Kasey Lee's sort of mysterious surgical assist, which we don't really have details on. He doesn't disclose that information for whatever personal reasons, maybe to protect his procedure from other people doing it. I'm not sure. But with his surgical assist, which is through the nose, it's endoscope assisted, hence ease, endoscope assisted surgical expansion. This expander is able to, purportedly achieve a parallel posterior expansion, a parallel front to back, as compared to the custom MARPE or MARPEs in general, which achieve this sort of more conical expansion, or at least so the naysayers purport. Okay,
Mhm.
but I want to give you a chance to make the case. And here's my MSE, by the way. So this is not ease. This is Juan Moon MSE. My MSE was obviously, you know, the expander has been through 86 turns at this point, 84 turns. It's completely mangled. There's possibly flaring of some teeth, but you can see that the appliance was posteriorly placed at my first molar, right?
Mhm.
So whereas the custom MARPEs are more anteriorly placed up here toward the ANS area, where the bone is much thicker. So I want to give you a chance, doctor, to respond. And here's another image, ease after 10 days, where you can see uh, this is just 10 days post-op. You see a parallel split front to back, where you have a gap forming at uh, the PNS, the posterior nasal spine, the back, which is sort of the supposedly the gold standard of where you want the expansion in order to have airway benefit.
Mhm.
Um, all right, I will let you respond, doctor. Here's one more image with ease. See, you get this robust posterior expansion, or at least in this case, with this KLS Martin expander, which is placed at the first molar, as opposed to anteriorly toward the front of the maxilla.
Mhm.
All right, that's my steelman argument in behalf of ease and against custom MARPE, represented on the right in this photo.
Mhm. So, can you go back to the clinical pictures of the KLS Martin expander?
This image,
The clinical, the intraoral photos.
yes,
Yes, thank you. So when you look at the placement of the device in this image is not placed posterior and is not placed anterior. It's placed exactly in the center of the maxilla from the front to the back. Um, the reason why in some of the case, can you go back to the 10-day after ease image that you showed recently?
this one,
Yes. So when you look at this 10-day post-op, and you're saying that the opening of the midpalatal suture is parallel from the front to the back. My understanding is that the ease activation is very minimal, very slow. Otherwise, the expander would fail and cause impingement on the gingiva. So I think what you are seeing on this image at day 10 is the activation that the surgeon got during the surgery, not much at home. The patient may have just started to turn, so you are really seeing the surgical cut. So this is a surgical cut. This is not the expansion that we see on those CBCTs. And although the cut looks nice from the front to the back, that's great. And I understand that this cut is done with the endoscopic approach, um, which we also are trying to achieve with the two-pan approach at the University of Pennsylvania Sleep Surgery Department. So I like the cut, but I would like to see this patient after the expansion, after all the turns are completed, because I have seen enough patients after ease where this widening that you see in the paper that you just shared where you have a beautiful wide opening of the midpalatal suture from the front to the back. You just don't see consistently on all the patients. Like this is great, and I like the idea. This is more posterior placement of the screw on this image for sure, and I like the control where if you need more posterior expansion, you place the screw more posterior. And you get less diastema, less opening in the front. That's awesome for some of the cases, but some of the cases really require more anterior expansion, unlike this case. But it's not a consistent outcome. And we can't really claim that this is the only procedure that will achieve that posterior expansion. So now we have MSE is not a custom appliance. That green diagram that you have right there on the top, this is not a custom MARPE. This is an MSE 3D modeling of the screw of the MSE expander. So this is not a custom approach. And yes, MSE, you can place more anterior, more posterior. Hopefully the screw will fit where you need it to be placed, because some of those MSEs that are pre-made just don't fit in a very narrow palette, whether it is anterior or posterior placement. MSE has limitations. So the custom MARPE is a little bit different. You don't have here images of the
Uh,
custom MARPE, right?
I can pull up some images. I just posted some on
Mhm.
my Instagram because I attended Dr. Lipkin's course. Uh, I just to give people a sense. You're right; those are definitely not custom MARPEs, and that's my mistake for saying that they were. I guess I thought that the one on the right was because of the two added tabs, and I guess you could say it's a customized MSE.
Customized MSE, yes,
Right.
modified MSE. So with the MARPE, you can place the screw where you want to be placed. It can be placed more posterior, more anterior, in the center of the maxilla. So do the implants. You can customize placement of your implant fixtures. You can customize the screw position, customize the anchorage on the teeth based on what the patient needs, whether they need more anterior or posterior expansion. And I
Right.
don't know if I can share my screen right now.
You can. You can. I just for a moment I have loaded up some of Dr. Lipkin's custom MARPEs.
Mhm.
And can you confirm that these are custom MARPEs, something like this?
This is custom. This is fully custom. I use a little bit different protocol, but you are limited by your, with the custom design, you're limited by your imagination.
Right. But as you can see here, uh, Dr. Lipkin definitely has some TADs placed at the second molar, first molars, I guess.
Mhm.
Um, and so these holes here would almost be mimicking the ease a KLS expander, because you can see that the TADs aren't even going to be perpendicular to the expansion screw. They're they're not quite parallel like the KLS Martin expander, but they're definitely angled to sort of go with the expansion, right? Could you comment on that?
Yeah, so these implants in between the first molars and premolars are placed laterally. They are placed more in between the roots. I don't use this type of design for my patients, but some doctors like it, so that's fine as long as it works for them. But I cannot say that this is exactly simulating KLS Martin expansion.
Mm-hmm.
I think once you introduce surgical cuts, this is a different type of situation than you try to achieve expansion without any cuts. The way the forces are transferred from the device to the bones is different. But yes, these implants here you can see implant placements along the midpalatal suture and lateral as well. Uh,
Uh, in
mhm,
this one, the one on the right,
mhm.
along the suture, one, two, three, four, and then uh,
Lateral placement of the implant.
lateral placement here and here
Mhm.
at the first molar.
Yes.
Okay. And why? Could you just very briefly and comment as to why you don't feel the need to use parallel anchorage? I'm sorry, lateral anchorage.
I think that I would rather use the implants along the midpalatal suture and have my forces along the bone that needs to separate. I don't think if you place a band and the lateral implant, it's going to add much to your anchorage. And I also have seen situations where uh, those implants are not fully engaged in the bone. I had doctors that contacted me with complications from this design. So I do it a little bit differently. But I'm not saying that this design doesn't work. I think that if you introduce implant placement a little bit differently, it may give you a little bit better chance to open the mid-palatal suture parallel in a parallel pattern without any piezo, any type of surgical facilitation.
Okay, and jumping the gun once more, but why don't you like the piezo?
Why don't I like piezo? So basically, uh, it's not that I don't like the piezo. I set a goal for myself is to determine the limit of non-surgical expansion. So what happened in the past when I talked to my colleagues, when the MSE expansion was introduced and we started to place MSE expander just like Dr. Moon suggested at the level of the first, with the screw position at the level of the first molars, the bands on the first molars, you showed in a beautiful diagram that the bone is very thin in that area and it's more posterior placement of the screw, so we had a lot of failures. And so
Hmm.
a lot of doctors that got these failures automatically jumped into the um, perforations, like bone perforations along the midpalatal suture to ease the expansion, and then the piezo was introduced. So basically, all of these surgical facilitations were introduced before we kind of understood, did some research and understood why we are seeing those failures. So I decided, like, if you start jumping and adding all these surgical procedures, we will never be able to understand the limit where the patient is going to open without any surgery versus with the surgical facilitation. So I tried the utilizing piezo with the MSE in the past. I tried utilizing the perforations along the palatal suture. So the same patients, which in the past was male, adult male patients older than 30 years old, didn't open without these procedures, then open with these procedures. And I said the design is too weak, so it had to be with the design. So my practice is focusing more on the design, utilizing the design and understanding where the limit of the design stops, that we have to introduce the surgery. So I will try without any type of piezo, any type of perforations, to utilizing just the design of the custom appliance to see my limit, where the bone is going to open and not. And the patients are opening.
Hmm.
So
Hmm.
everyone is opening. Maybe I have right now like one or two patients, no more, one or two patients out of many patients that we have done it on and are doing it on, that didn't open yet, didn't split yet, but doesn't mean that they won't split. They just didn't split. I placed the device within a month. Usually,
Hmm.
the patient will split within a few weeks or days after placement. So I want to understand the limit. And I think if I do it without any surgical facilitation, I think I have a great result, a better outcome.
Hmm.
So
Now
I,
you did say earlier, doctor, though, that there's some kind of surgical assist that you're working on at some academic institution that's similar
yes,
to the ease.
yes,
So then you can acknowledge that there is a use case. It does help to free the sutures, though, doesn't it? How could it not help? I understand your point,
mhm,
though, that if you can find a design that can split without the extra help of the assist,
mhm,
then you've made tremendous progress. And then with the assist and the best design, then you could split a caveman, probably, right?
yes.
Not that you need to.
So the problem with the surgical assist that you still have to do your lateral cuts. Um, so you still have to release the pterygomaxillary sutures, and you are not getting the same expansion all the way to the to the glabella like you would get with the non-surgical protocol.
Hmm.
So I think we s- we still have to study so much in this area, but I am not. When I look at my results, I think from the invasiveness and from the clinical outcomes healing, the patient experience is so much better with non-surgical versus with any type of surgical facilitation.
You
So
mentioned just now the pterygomaxillary suture, right?
Mhm. Yeah,
Is that this suture here circled in red?
yes.
Okay, can you comment as to what resistance does this suture play when it comes to nasomaxillary expansion? This seems to be something special about this, and I'm not entirely sure. As I said, there's something mysterious about Dr. Lee's surgical assist, but am I correct that this is sort of the magic of the ease is that he releases the pterygomaxillary suture?
I cannot really comment. I think I understand that he releases it, but I can't really comment what exactly he does because it's not very clear. But this suture presents significant resistance. But again, once the midpalatal suture opens, this pterygomaxillary area, not the suture necessarily, but pterygomaxillary area at some point of widening of the maxilla is going to open.
Can you point in your face as to where the pterygomaxillary suture is and like where is that? Is that here, like behind the?
It's
It's right behind the.
behind your last tooth of the upper jaw. It's all the way behind your upper jaw. It's like I cannot really point on the face. It's behind the ramus of your lower jaw.
Okay. Um. It's just so hard to visualize these things. Um. Okay. Here, let me just do this. So, are you seeing my screen, doctor?
Yes, yes.
So, this the area of the resistance? Sort of.
There are many areas of the resistance, but this is one of the areas of the resistance. Yes.
That's so funny. This is actually my website. I don't even remember posting this. I must have done that 2 3 years ago. Okay, so um, now you were saying if you can get the split, then this area becomes less of a concern. Like once it breaks, once it budges, it budges. Can you flesh that thought out? I was a little distracted because I was searching for images.
So it's very so this area has to open in order for you to widen the maxilla in the back. But
Hmm.
either surgeons break this area or this area breaks during activation of the expander, and it won't always open exactly at the level of the suture. It will open in that area at the weakest point of resistance. So it could be going through the pterygoid plate, it could be going through the pterygomaxillary suture, but this area has to release in order for maxilla to widen posteriorly.
Hmm. Hmm. Okay, so you're saying it's not necessary. It's not necessarily the case that you have to surgically release it. If you can get maybe you can get the expander to break this resistance point, and then you've accomplished the same goal of releasing the posterior part of the maxilla to be expanded.
Yes, so this area can open without the surgery and it can be broken with the surgery.
Okay. And the surgery that you're exploring at your institution or with your group, would it involve a release of the pterygomaxillary suture
Yes, it
surgically?
involves two-pan approach involves releasing of that suture.
Okay.
But remember, when the surgeon releases this area, there is a risk of bleeding, number one, and there
Hmm.
is also a chance because the procedure is done blindly that there is incomplete release or there is no release. It's very difficult, and I understand some surgeons say they can feel when they have done a successful release, I respect that statement, but when I look at my patients' CBCTs that had the surgical expansion with traditional approach versus with the two-pan approach or dome, I have had cases where that area did not open at all, and I had patients that had a conical expansion where it did open more anteriorly and then open much in the back. So
And what is the two-pan approach, roughly, if you can disclose?
So the two-pan approach is basically a traditional SARPE or surgically assist approach when it comes to the releasing lateral surgical release of the maxilla laterally and anteriorly through the midpalatal suture. The bone is released in the front, but with the endoscopic access into the nasal cavity, the surgeon undermines mucosa of the nose and goes all the way to the back and releases maxilla in the back with piezo knife through the nose.
Right here, basically, right? The near the PNS?
At the area of the PNS. However, the one of the most significant resistances in the sutures is actually the connection of the vomer bone to the palatal bones in the back of the maxilla. And sometimes that suture is so dense that the surgeon will go around the connection of the vomer to the palatal bones and release the maxilla laterally on either one side, on both sides. So, in other words, the maxilla is surgically released all the way from the front to the back.
Mhm.
So the surgical release of the maxilla from the front ANS to PNS doesn't equal the parallel opening of the
Mhm.
suture from the front to the back because it also depends on the appliance design and the position of anchorage. So even if you release that maxilla from the front to the back and you place your expander more anteriorly, you will often see more anterior expansion.
Now,
So
doctor,
yes,
because of the nature of the vomer bone, and because it is like a centrally located structure, is it possible to even split the vomer, or do you just have to settle with splitting on one side or the other, which would leave the vomer either free floating, or would the vomer then just sort of remain fixed to one half of the maxilla, and it would then therefore end up being sort of asymmetrically placed in the final result? How does that work?
So with the two-pan protocol, the VOMA is either released completely and it's floating,
Hmm.
or it's more released on one side. So there is another variation, another thing that there is a significant variation in that anatomy in that area. And even with the surgical access through the endoscope is not very easy to release it the same in each patient.
Hmm.
So when I look at my patients, yes, we want to release it right, like you showed from the front to the back, but sometimes it's not possible. And I am not sure whether it is good to let the warmer float and completely cut it on the bottom of the flow of the nose. So I don't know. So that's why there are a lot of I don't know here uh,
Right.
to properly answer your question. But there is one thing for sure that you can achieve more parallel expansion from the front to the back, not only with ease, but with other protocols, whether it is two-pan approach, whether it is non-surgical protocol. I
Hmm.
think it's difficult it depends on the patient as well, but it is not right to claim that only one procedure can achieve a parallel opening of the suture from the front to the back.
Hmm. Hmm. And do you suspect that Dr. Kasey Lee is doing something with the vomer during his e-surgical release? Do you have any thoughts on that? How he deals with the vomer?
I don't know. I don't know because again, he doesn't disclose his surgical protocol, so I have no idea what exactly is being done. But I understand he accesses the posterior portion of the maxilla also through the endoscopic approach.
Why don't you think he reveals his surgical protocol?
I don't know. I
Me
can't
neither.
comment on that.
Me neither. Okay, I want to give you a chance to make your case that uh, we can achieve a parallel split using perhaps your design or something other than ease. Um, do you want to go ahead and show us that?
Sure. So I just click on present, right?
Yes, let me stop sharing and then click on present and um, that, and then you'll be able to select a tab, a window, or full screen.
Okay. So um it doesn't show for me. A window, okay. Perfect. Okay, can you see my window?
Yes, I can.
Mm-hmm. So this is, so I think the trick is not in female patients, but the challenge is in adult males older than 30. What kind of expansion can we achieve in these patients? Can we avoid surgery? Today, when I talk to my average patient, everyone wants to avoid surgery, right? Nobody wants
Hmm.
to go through the surgical procedure. And if the patient needs MMA surgery and expansion, you want to try to avoid two surgeries because sometimes you have to do two surgeries to achieve expansion and to achieve advancement of the maxilla and the mandible. So here you have two patients, two male patients older than 35 that have a parallel opening of the midpalatal suture from the front to the back. Do you see that?
Hmm. Can you show us what the appliance looks like in these cases? A clinical photo that shows the
Sure,
intraoral image?
sure. Let me see. So let me just go through a few slides and then I'll show you.
Please, by all means.
So here is the intraoral pictures of this technique, and you can see that there is no taping of the molar. So this is adult patients older than 40, for example, male patient, and you can appreciate that the molars are upright. I don't have any taping in the posterior teeth that are anchored to the expander during expansion. I have beautiful diastema that opened from non-surgical protocol, very similar to the one you get with surgery. Although I think surgical diastema is more traumatic to the anterior teeth because you can compromise periodontal support and special ligament that connects the teeth. It takes much longer to close surgical diastema than to close diastema without surgery. And I think when it comes to risk of root resorption with the surgical expansion, you probably have more risk of root resorption than with non-surgical expansion protocol.
Hmm.
So again, you can see the parallel opening of the midpalatal suture from the front to the back and anterior nasal internal valve. You can see change. The patient couldn't breathe through the nose in on the right side. So you can see how much the nasal valve opened after expansion. Now suddenly patient can breathe through the nose on the right side.
Right. So before is on the left, after is on the right. That's a dramatic increase in nasal volume.
And with clinical improvement. So the way we checked it, we asked the patient, what do you feel different after expansion? And the patient reported that he was never able to breathe through the right side of his nose. Now suddenly he's able to breathe through the right side of he can feel the airflow. We take a CBCT and CBCT shows anatomic opening of the right side of the anterior nasal valve. So for
And
some,
here, the right side is on the left side of the left
yes,
nostril is
yes,
actually the right
that's
nostril.
correct. That's a mirror like image, but the
Hmm.
right side is the left on the screen.
Hmm.
So then, when you look at the sutural opening, traditionally we know that in children after age 10, if you are lucky, you will get 50% of expansion in the bone as compared to expansion in the screw. So for this case, we went from 28.8 millimeter width in the maxilla on the inner aspect of the maxilla on the palate at the level of the first molars to 35. So we got good 7 millimeter of skeletal expansion here. When you look at the percentage of bone to screw expansion, which is a very important parameter that I measure for my patients. So you have 85.7% of skeletal expansion, which is unheard of for adult patient, male patient older than age 35, from one expander, from one screw.
Mm-hmm.
Sometimes with MSEs, including myself, I had to use multiple MSEs to get a little bit of expansion, not always even the amount that I need. So I had to go through several expanders to achieve expansion. Here, with custom approach, I get more expansion without surgery in adult male than I get what is reported in children older than 10 in the orthodontic literature. So this is insane.
Mm-hmm.
So the design of the appliance is limited to your imagination. I like to place my implants along the midpalatal suture. So sometimes, if I need more anterior expansion, I will place it more anterior. So this is a female patient on the right. You can see more anterior placement of the MSE. So that's pre-made, prefabricated design. Worked great for that patient because that patient needed more anterior expansion. But then for the male patient that needs more parallel expansion, for example, I will place it more from the front to the back, utilizing the whole palate, not just anterior portion of the maxilla, not just the central portion of the maxilla, and of course not the only the posterior portion of the maxilla, because you can see how thin the bone is.
Mm-hmm.
I use the whole maxilla from the front to the back without piezo, without surgical facilitation to split males, and it works.
Mm-hmm.
And if I need to use the same protocol for the female that has thicker palate, I'm going to use the same protocol for the female patients. If I have to expand more maxilla in the front in the male, I'm going to utilize the protocol where I place my implants and the screw more anterior. But if I have to use the expander to open it more evenly, like I showed you earlier from the front to the back, then I customize and I place the expander from the front to the back with implants and tooth anchorage to achieve that parallel expansion from the front to the back. Mhm. So,
Doctor, you spoke earlier in the previous slide about the ratio of
mhm.
the expansion of the expander versus the expansion that we see in the maxilla.
Yes.
What about the ratio of the expansion of the diastema versus the expansion of the molars?
Yeah.
So that's the ratio that determines
From the front
how
to the back.
how conical the expansion is versus how parallel it is.
Mhm.
Have you tracked that in the case of like a male that you just showed that had the more posteriorly placed expander? Because I think this is really the crux of it, right? If if you can achieve that parallel expansion and get a 1-to-1 ratio or similar using the custom design, then we have a solution to the problem that everyone is sort of complaining about.
Yes. So what I agree. So today what we really badly need are the studies comparing all possible techniques, because even if you talk about the design that you showed of Dr. Lipkin, it's not exactly the design that I use. So it's not easy to compare. We are not comparing apples to apples, right? So
Mm-hmm.
I think if you want to get my personal opinion, I think today we are practicing in the world that we have technology, we have the tools to diagnose, to plan, and to deliver design the appliance that is going to be customized for each patient. Some patients may require that ease approach once we understand exactly what that is. And so I would like to also separate the ease surgical approach to the ease screw that is being used. So
Mm-hmm.
maybe the ease surgical approach is brilliant. And with, I'm not really that impressed with the screw that is being used, because now we have developed new technology that allow us less invasive installation of the design of the appliance and more customized approach to patient's palate. So I think the technology of the screw and expander has significantly improved. We don't need to use KLS Martin screw, but the surgical protocol where you, for the patient that really needs to open more posterior portion of the maxilla without opening diastema, is extremely critical for some patients, where you don't want to interfere with that anterior maxillary anatomy at the level of the teeth and then use months of orthodontic treatment to close a huge diastema. So that's
Hmm.
brilliant. So
Hmm.
I think there is a population of patients that will benefit from that protocol. Or you can use in some of the patients that you know and predictably, based on the data that we have today, uh, say that you should do non-surgical expansion, and utilizing this design without any surgical facilitation, this will work for you if you use this many implants and you use this implant placement with this turning protocol. It's also about turning protocol. So now we can even um, customize the turning protocol. Maybe the suture will open parallel from the front to the back, but you don't open a huge diastema based on your turning protocol, how many turns you turn a week or a month. So I think we have an amazing opportunity today to have all these tools, technology, those CBCTs that we can put in one box and see which surgical techniques, piezo technique will work for which patient.
Hmm.
So
Hmm.
all we are talking about claims and discussions, and they are great, but until we have a study to really compare all these different techniques, and we are right now in the process of putting the study together between different practitioners, different practices, I think only then we will be able to clarify some of these questions that we have.
Sure.
But there is no question that we are leading toward less invasive approach. And if we can achieve uh, the results that I'm achieving on the majority of my patients today without surgery, we are going to do it without surgery, because that's the right thing to do.
Sure.
Surgery is going to be done when we don't have a choice, or we failed, or we know that surgery is really offering better outcome than non-surgical protocol.
I agree with you that avoiding surgery is universally a good thing if it's unnecessary. But do you think, though, it's worth distinguishing between something like the piezo cut, the way Dr. Lipkin does it, versus like a dome? Because if you look at the dome procedure, it's uh, it's completely in a category of its own as compared to Dr. Lipkin's piezo cut, which you don't even see blood. When I went to his course last weekend, he demonstrated it live on a patient while we were all there. There, you don't even see bleeding. It's a like a 8-minute procedure where he just goes in and basically this is the model that he had us practice on. All the attendants, I was the only non-doctor, obviously, but he guided my hand as I did this with the piezo knife. um, you go in here above the two front teeth, carefully avoiding the roots of the teeth so as to minimize the issue you spoke of earlier, which is possibly compromising the ligaments or the roots of the teeth. And then you come through here as well. The thing takes like 5 minutes to do, and there's not a drop of blood, and apparently the patients react pretty positively to it. He does it right in his office under local anesthesia. That's nothing like the dome surgical assist, right? Can we
Yeah,
can
of
we say
course.
that?
It's nothing like a dome, but in the same time, it's still a surgical procedure. And there are complications from piezo. We have
Hmm.
been doing piezo for a lot of periodontal indications, and piezo is not without complications. So, what I'm saying is, my point here is it really necessary? If you can achieve, if I get a result without piezo, why would I want to do piezo? To
True.
do piezo between the front teeth that are very crowded, there could be a complication. to the periodontal support of these teeth, and it could be a complication that is going to be more significant than doing it the way the surgeons break the bone with the chisel. So I think I am very cautious. As a periodontist, I'm very cautious to introduce any type of surgical intervention to be used in the traditional orthodontic practice by a provider that is not doing surgery. So I think piezo is a great tool when it's necessary, but when it's not necessary, don't use the piezo. And it's also a tool that is designed to be used by a surgeon. So I think that the orthodontists, although it looks like it's very easy to use, need to be properly trained to make sure that they don't face the complications that you can get with piezo. That's what I'm trying to say here.
Sure, sure. Like necrosis, for example.
Like a non-union of the bone. You can overheat the bone. There are different phenotypes of the bone. In some patients, you have a very soft bone and the piezo goes through very easily. But in some patients, you can really get overheating of the bone and achieve non-union. And I think if you can split the bone without piezo successfully and predictably, and that's what I'm trying to do. I'm trying to split it without piezo, and it splits. So why would I want to open any type of wound and do any type of surgical cut when I can achieve it without surgery? So I think in the end, probably there will be limited number of patients that will benefit from the piezo facilitation, any type of other surgical facilitation uh, based on the patient's anatomy. But I think based on the tools that we have with the implants and the customized the 3D planning, you can avoid piezo in the majority of the cases.
Again, I agree with you.
That's
Surgery should only be
my
done if
conclusion based on my experience.
I, look. I think surgery, if unnecessary, obviously should be avoided. Right. Um, just a last word in defense of at least Dr. Lipkin's use of the piezo. He in his course where he teaches people how to do it. He goes through a whole series of complications that can arise from piezo, such as overheating, and then instructs how to avoid it, such as by making sure you don't hold the piezo too long in one place, causing overheating, sort of dipping it in and out to allow fluids to enter and cool the site, again, to prevent overheating. And of course, to make sure you do not go too low down toward the roots of the front teeth to avoid uh, uh, giving those teeth a death sentence by, hitting the roots or, cutting through the skin down at the site where the gums meet the teeth.
Mhm.
It can definitely be done skillfully versus unskillfully, and but either way, to your point, if you can design an appliance so that it's not necessary, then even better.
Exactly.
Can you show, doctor, an image of one of your designs that you might use for an adult male who requires a more parallel split?
Sure. Let me see. Can you see?
Yes, I can. Wow, look at that, huh? That's a beauty.
Yeah.
Now, doctor, do you place those posterior screws closer to the, can you keep that up, doctor? I'm
Sure.
sorry.
Sorry, sorry.
No, that's okay.
Can you see?
In a second, we will be.
I got it.
There it is. Now, those posterior screws on that appliance, you said you like to place them close to the midpalatal suture.
Yes.
Is that because the bone is denser there, closer to the midline, and the screws have more of an area to grab?
So in the back of the maxilla, if you think about lateral placement, you can actually create a lot of the soft tissue impingement. So although the bone looks very thin in the very back, I want to engage the palatal bones. So if you can see, my posterior implants are placed behind the transverse palatine suture. So it's actually placed in the palatine bones. And
Mhm,
the cortical bone is strong enough to get good primary stability for those implants in the back.
mhm. So just, on this point, because this is a point that was brought up in my Discord server, and I think it's really insightful, and I think that the way you're doing it is in accordance with the point that's being made. So if we go back to this image, right, you can see that in the posterior, as you go further away from the midline, the bone gets thinner. But
Uh,
are you seeing my screen?
yeah, yeah, I am seeing your screen. Yeah.
It looks like your TADs are being placed as close to the midline as possible,
Hmm.
um, so that they can engage in this thicker
Dense
bone.
bone.
Is
Dense.
that a
It's not
consideration?
thick bone. It's dense bone. But
Dense bone. Okay.
some patients have thicker bone. Some patients have thinner bone in the very back. So there is also variation in the thickness of the bone and density of the bone from the front to the back. So this diagram doesn't really represent individual patient. It represents an average. So
Mhm,
you have to design based on the patient's bone density, bone thickness, and length of the maxilla from the front to the back.
mhm, mhm. Okay. Could you add your expander back to the screen, one more time just so that we can talk about it a little bit more?
Can you see?
Yes, I can see your whole screen. Yep, that's perfect. 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 And, is this the expander that was used with the CBCT you showed earlier of the
Yeah.
parallel split? Mhm, mhm.
So
So this case.
this is not only mm, like this is just one of the designs, but this is a very predictable, very reproducible design that works great on adult male patients without
Mhm,
piezo, without any surgery.
mhm, mhm. And with achieving that posterior expansion that seems to be the gold standard amongst the, um, I don't wanna call them the naysayers, but the adult male sleep apnea patients who rightfully want to make sure that if they're gonna go through a process like this, that they're actually gonna get the, uh, airway change that they want inside the nose and perhaps at the back of the maxilla.
Yes.
So, I mean, in my opinion, this case here, and maybe we can end on this as we approach 1 hour of our discussion. This case here is a counterpoint to the people who say that the custom MARPE is unsatisfactory when it comes to posterior expansion. Boom.
Boom.
There's your rebuttal.
Well, it's again, you have to have a study to really say, support what you are trying to say. I am just adding some insight and light to the discussion that is still regarding something that we haven't fully studied. So I'm saying that now we have the technology to avoid surgical facilitation to be able to open that suture more in the front or parallel from the front to the back, again, based on the patient's needs. And of course, there are going to be complications, there are going to be failures with any type of approach, but we really have to have research to understand the the chances of these complications. Like when I look at my patients that have complications, I can I was recently reviewing all of my surgical expansion cases that had the surgical expansion versus non-surgical, and the
Which surgical expansion? Dome?
uh, dome or traditional surgically assisted expansion. So I can say that the 99% of the complications or complexities of treatment that I have been facing has to do with the surgical expansion, not even comparable to what we achieve and have to deal with the non-surgical protocol. So with my eyes closed, if I can avoid surgery, I personally waited 10 years to be able to expand myself without surgery. So I know what I have to do to get the treatment from start to finish for patients that go through the surgical expansion. So I waited 10 years to be able to expand myself without surgery. So I'm a very strong advocate of a minimal invasive approach. So if you can avoid surgery, you have to avoid surgery, because I think the outcomes could be more superior and less invasive and more gentle to the patient, to the bite, to the teeth, to the airway, if you do it without surgery. And I'm
Mhm.
talking about not only intraoral complications or challenges that we face with the surgical expansion, but also with the nasal anatomy. So I think I would like to finish my discussion on this, because I actually have to go. But I think it's a great discussion. Thank you so much for organizing it. And I think we have a very exciting future when it comes to expansion in front of us.
Yes, we do. I think that the field is starting to hone in on it, and thanks to the Partners Dental Studio, that you're able to make these custom designs and experiment with them and see what they're capable of. And I'm excited that because of people like you and your skill and your willingness to try to solve these problems, that a lot of adults with sleep disordered breathing are going to be able to get a meaningful improvement in their quality of life, because of course not sleeping well is a death sentence, and even while you're alive, it's a low quality of life, and people are really really in need of um, solutions, and hopefully even non-surgical solutions.
Yes, thank you so much.
All right, thank you so much for your time today, doctor.
Thank you so much. Thank you.
Okay, bye bye.
Bye.